Good morning, everyone. My name is Bob Holloway, and I am honored and I must admit a bit intimidated to give this talk, Palliative Care and the Art of Leadership. I do not profess to be an expert at all on leadership. I struggle with it on a nearly daily basis and never think I got it quite right, but I keep on trying as best I can. I would also be remiss if I did not point out the obvious. I am a white male giving a talk on leadership at a time when we urgently need more diversity in the ranks of academics broadly and in leadership positions specifically. But Benzie asked me about 9 months ago, and as many of you know, it is hard to say no to Benzie, so I agreed. What I hope as I reflect on my various roles and in preparing this talk is that I can be the most inclusive and equitable version of me, such that I can leverage what I know in service of all who I'm accountable to, including all of you in this wonderful new society. Leadership in healthcare and in academics, medicine right now is more important than ever, and it is also vitally important at the birth of a new field. Therefore, it is an honor to reflect on this topic and at this inaugural meeting when our new society is taking flight. I have nothing to disclose other than these NIH grants. So how did this talk come about? As some of you know, I am both a neurologist and a palliative care physician. While training and practicing neurology in the 90s, I found my passion in palliative care and at its intersection between our two fields. With my wife's encouragement, I pursued it, rode Tim Quill's coattails for a while, did the practice pathway, and became boarded in 2008 when they gave the first exam, and thankfully passed the research exam 10 years later. I've continued to do both while juggling academics through the years, never knowing where it would take me. In 2012, almost 10 years ago, I was privileged to become chair of the Department of Neurology at Rochester, where I trained 20 years earlier. And for the past decade, that's what I've done. I've been chair of a department of over 115 faculty, 65 residents and fellows, and 500 staff. It's been quite a ride, particularly over the last 19 months. And this is what I noticed early on as chair, and have I continued to notice it ever since. I'm always using my palliative care skills, whether it be deeply listening, running meetings, thinking about the future, talking about tough news, confronting brutal facts, or reframing hope. I am constantly weaving in those skills I practice at the bedside. Over the years, I've talked about this surprising benefit to many, including to Benzie, who in turn asked me to share my thoughts with you today. The basic premise is this, that we, the hundreds of us who have registered for this meeting, have this surprising benefit in waiting. Indeed, that passion and that labor of love you call neuropalliative care, it equips you with the building blocks to become future leaders, to create a world where high quality, person-centered care is available to all people and families affected by neurologic illness. So as we reflect on Benzie's inspiring presidential address and his 10-point vision for the future, we have to ask ourselves, what will it take to get us there? What it will take is a leaderful society that creates change and then manages it, precisely what leaders do. And we can do so by tapping into the many skills you use so naturally. So here are the objectives of my talk: to appreciate the importance of a leaderful society to achieve our vision, to review the gaps in our clinical training programs to prepare us for leadership, to review the leadership in medicine and what it looks like in 2021, and to provide you with examples of how to leverage your palliative care skills in leadership and advocacy roles. We will conclude by having a panel discussion with members of our society who have extensive leadership experience, leaving ample time for discussion. We can view this work as a reinforcing feedback loop to first identify and fill the gaps to prepare us better for leadership positions, the upper arrow, and to second, cycle back and leverage our palliative care skills in leadership and as advocates, the lower arrow, and on and on. And if we do, we will be well positioned to accelerate change and shift culture to not only launch and take flight, but to soar and achieve our moonshot goals over the next decade. The leadership coaching business is booming, and there is an urgent need to cultivate new types of leaders in medicine. Leaders who can promote cultural and strategic alignment in the face of rapid change. Leaders who can deftly operate in complex environment with diffuse power structures like academic medical centers. Leaders who can motivate, advance equity, and cultivate well-being for the greater good. No easy task, particularly in today's environment of a pandemic, labor shortage, shifting social codes, and heightened expectations. Maureen Bisignano, the President Emeriti of the Institute for Health Care Improvement, said it well. When you can marry the leadership skills and the clinical background, you have an opportunity to lead in a very distinct and different way. When you get someone who knows what quality looks like and pair that with a curiosity about new ways to think about leading, you end up with people who are able to produce dramatic innovations in the field. So what are the gaps that exist in leadership training within our clinical training programs? Over the past several years, this has received some, albeit limited, attention. These are three of the publications. The most notable one is the top one. Geriatric and palliative medicine leadership is needed now more than ever. What are the training gaps? This was published earlier this year in the Journal of the American Geriatric Society. The authors surveyed and interviewed 22 leaders of palliative medicine and geriatric about the perceived gaps in their training and what they wish they knew upon taking their first leadership position. The authors grouped these gaps into a knowledge domain and a skill domain. The reported knowledge gaps were finance and budgets, health policy, health systems, and population health. Here are the sample of quotes from leaders interviewed about the knowledge gaps. The things I needed most were financial planning, budgets, strategic development, and sort of a larger awareness of an organization as a whole, and maybe pieces around regulatory affairs. Or I think just public policy savviness and what are the macro trends driving why and how we practice and why models of care change. And you have to figure out a way to understand where these multidisciplinary care models can lead to value creation and means of getting paid. Now, this slide highlights what the interviewees said about the skills or the additional competencies they wish they had. Advocacy, communication, mentorship, negotiation, and self-awareness, which actually includes many of the skills thought of as emotional intelligence. Referring to these competencies, interviewees said, I think that it is a great time to be in palliative medicine doctor in healthcare today because US healthcare is shifting from volume to value, and so our content expertise is in models of care that support value-based care. Or one of the things that we learned in fellowship was communication, and we learned it really well. I did not realize how well we learned it until I got into these positions. And I was like, this is just like having a family meeting. And one of the most important things about leadership is self-assessment. Understanding why people would and would not follow you is an important exercise. This is a summary wheel of the needs and challenges that the participants reported facing in their initial leadership positions. They are grouped into these 5 gaps: communication management and apprenticeship, program development, and mentorship negotiation. This actually can serve, I think, as a nice starting point for developing an individualized leadership plan for individuals. Now, while these insights and these gaps are important and reinforcing, the most important result of this study, however, were not these gaps, but it was this: that 50% of those interviewed had leadership positions within 1 year of graduating. And 100% of those interviewed had leadership roles within 6 years of graduation. This accelerated ascent into leadership roles will no doubt play itself out in our field as well, given how new and dynamic the evolving landscape. So let's roll up our sleeves and all consider developing or updating our leadership plans. Leadership programs are everywhere these days with a whole suite of offerings within our specialty societies, our home institutions, and programs offered in many business schools and academic medical centers. In fact, Janice Miyazaki and I spent 2 weeks together in Boston in 2006 when we attended the Harvard Leadership course for physician leaders in academic medical centers. That course still exists today and covers many of the topics from the prior 2 slides. To emphasize this urgent need to develop career paths and cultivate leaders in our field, 2 years ago, I changed the role of Associate Chair of Academic Affairs within our department to the new title, Associate Chair of Leadership and Career Development. This role is intended not only to provide leadership and career paths for physicians, but for all members of the care team. Now, one should not underestimate the hard work needed for leadership, as stated in this quote by Simon Sinek. Good leadership is always human. It takes time and energy. It is hard work, which is why good leadership is so special when we find it. Leaders are made, they are not born. It is a skill that is constantly worked on. It requires self-reflection, authenticity, practice, honest feedback, and constant work. This is similar to what we do within our own practice of neuropalliative care, when we self-reflect and ask what went well and what could have gone better while keeping tabs on both the short and the long game. This was the result of my 360 leadership review in the fall of 2020, about a year ago and 8 years after I started as chair. The slide shows the themes to the question, is there a specific area of improvement you recommend for your chair? I was grateful for the responses, and it revealed several weaknesses that I needed to work on, like holding people accountable, better advocacy for space and resources, a vision that is even bolder with more innovation, more time mentoring, and aspects of differential treatment and not listening to the opinions of others. Ouch. I have shared these results with my team and have committed to my own leadership improvement plan such that I can continually strive to be better in my role. Now, reading leadership books is like prescribing medications. You need to choose a couple from the thousands available and stick with them. You can spend your entire life reading books that essentially say about the same thing. These 3 I have found most useful. Good to Great by Jim Collins, which describes level 5 leadership as that paradoxical blend of personal humility and professional will. The 5 Dysfunctions of a Team by Patrick Lencioni, which emphasizes the importance of vulnerability to build trust and how to avoid artificial harmony that plagues so many teams. And The Culture Code by Dan Coyle, which explains why culture always eats strategy and ways to harness its power. Pick your favorites, keep them on your bookshelf, and periodically refer to them from time to time. At its simplest, leadership is about either reacting to problems or innovating to change the status quo. If one is leading to respond to a problem like a pandemic, leadership means identifying the right problems, solving them, and producing results. If one is leading to innovate or disrupt the status quo, like being a participant in the birth of a new field, leadership involves setting direction, aligning people, and providing motivation. That is precisely what Benzie did in his presidential address yesterday when speaking about the vision for the future of neuropalliative care. In both situations, however, it's all about people and that knowledge, mindset, and skill set needed to lead them. The effective leader can dynamically tap into these attributes on this slide and connect with people to create that flywheel effect that builds momentum around a shared future. Take a moment to reflect on the wonderful leaders you've been fortunate enough to work with over the years. What made them great leaders? What types of qualities did they possess? This slide likely shows some of these things that you're thinking about. They certainly had the knowledge to do the job, and I suspect the humility to admit when they didn't. As you can see by the descriptors, many refer to the social skills and emotional intelligence of leadership. And spoiler alert, where much of the overlap occurs with palliative care. You can appreciate it by just reading a few of these descriptors: self-awareness, listening and empathy, tolerating ambiguity, communication, team building, and collaboration, and many more. And over the last 19 months, the work of leadership has gotten harder, precisely because it's gotten even more human. The pandemic has put enormous stress on our clinicians and workforce and has magnified the gross racial injustices and oppression that exists across many of our societies. These two simultaneous pandemics, one going on for the last 19 months and the other for centuries here in the US, have brought forth the need for institutions and its leaders to double down on their commitment to respect, wellness, diversity, and inclusion. The first pandemic has exposed the long neglected second and has illuminated just how foundational inclusion, justice, and equity is for wellness. As our society grows, equity must be a central pillar in all we do. To celebrate the rich complexity in each of us, such that we can better care for our patients and each other. Over the past 3 years, these are the 10 leadership books I've read. I suspect many of us are on a similar complex journey of learning and exploration that are bringing increasing clarity about why our society looks the way it does and is the logical conclusion of what we've done in the past and in many ways continue to do. We've been way too ahistorical, and our way forward will be guided by this learning and remembering. This will require some deep digging and courageous conversations, but what better group is there to step up to tough conversations when needed? As positive interventions become the standard part of care and research, so too will cultivating well-being become a necessary work of leadership. This article by Tate Shanafelt, published in the October issue of the Mayo Proceedings, speaks to the evolution of wellness in medicine over the past 20 years and the importance of cultivating well-being in the workforce today. This focus, however, should not just be on physicians, but the entire team, enabling all to meet both professional and personal obligations. Accelerating this transition to well-being 2.0 will require teams that are not only lit up by clear signals of safe connection, but ones that foster and lift up truth and cause people to pause. Leaders will need new skills on cultivating compassion and emotional intelligence and strategies to provide effective interpersonal communications to allow teams to function at their highest level. So this is what leadership in medicine looks like to me in 2021, with the added features shown here in bold. We have to revisit the past and restore historical memory to hear the echoes of our patients and ourselves. And we have to not only have humility, but cultural humility and self-compassion to enable ourselves with the skills to advance health equity and cultivate well-being. While it should have never been the case, these bolded attributes were once viewed as nice to have luxuries in the leadership toolbox, but are rightly now urgent need to have knowledge and skills. We will never achieve our goals of delivering high quality, person-centered care, helping people flourish, or catalyzing high impact innovations without them. So these are the skills we have to learn. But as I've said, we have this surprising benefit in waiting. I want to amend Maureen Visignano's quote from earlier to the following. When you can marry leadership skills and the clinical background, you have an opportunity to lead in a very distinct and different way. When you get someone with a palliative care mindset and skill set who knows what quality looks like, and pair that with a curiosity about new ways to think about leading, you end up with people who are able to produce dramatic innovations in the field. That mindset of humble curiosity to learn as much as we can about the patient family in front of us, that mindset of learning to change the way we listen and cultivating a radical awareness to connect more deeply with them, that willingness to explore our biases, self-critique, and learn about the experiences of others, that courage to talk about difficult realities and to co-create honest roadmaps of the future, to comfort with uncertainty and the fortitude to make recommendations, develop a plan, and commit to walking the journey together. And that skill set of having serious illness conversations and establishing goals of care, that skill of collaborating and team building with the patient and family at the center, that skill to manage hope at the same, multiple hopes at the same time, and approaches to ease anxieties of the unknown, those practical skills of running family meetings and approaches to mediating conflicts when they arrive. And finally, our emerging skill to advance health equity and to promote the practice of positive medicine to enable everyone to flourish and reach their fullest potential. And by bringing these into our various roles, we can create kind of an unstoppable momentum for that shared vision of the future and accelerate this feedback loop of change. And in case you don't believe me, I will highlight a few examples of how I use my palliative care skills in my role as chair. I simply reviewed a 3-week period from October 1st to October 23rd, and this is by no means an exhaustive list. In fact, it's all in a day's work. So, for example, in palliative care, we have goals of care conversations. In leadership, we have mentor and career development discussions. On October 4th, I had my first of several monthly mentor and career development discussions. These are mostly around career planning, grant submissions, or upcoming promotions. Mentorship is about listening intently, understanding preferences, establishing person-centered goals, developing a roadmap, and practicing non-abandonment. It often involves managing a portfolio of hopes, including at times a strategy of hoping for the best and preparing in case things don't go as planned. Sound familiar? In palliative care, we run family meetings. In leadership, we lead and manage teams. I lead multiple teams a week, including our division chief meeting, the first Friday of each month. Just like running a family meeting, I set clear agendas, do my homework, over-communicate my listening, and resist the temptation to speak before everyone's voice is heard. Sound familiar? In palliative care, we have serious illness conversation. In leadership, we have serious news conversations. A corollary to this is that in palliative care, one needs the courage to talk about difficult realities. In leadership, one needs the courage to confront the brutal facts. The real serious conversations in leadership usually involve promotions, salary, or professionalism issues. Unfortunately, I had to have one on October 5th. Thankfully, these don't happen that often. Like in palliative care, I fire a warning shot, clearly communicate, and respond to emotions using, yes, the nurse mnemonic. And sometimes these conversations have to be framed using a least worst option approach. Sound familiar? These discussions are hard and may need to be done over a series of meetings. They take practice and they can themselves hinge on the effective use of one word or one phrase. Sound familiar? On October 7th, I had a very restless and sleepless night. I had recently learned of a faculty taking a new position in another city. While happy for them and an opportunity it brought, I also worried somehow did my leadership and the decisions I've made, the culture I created, contribute to their decision to lead. It's our job to agonize about our patients and our people. We need to self-reflect often and develop emotional strategies to handle both. On October 11th, I had a meeting with the dean to negotiate resources for an important faculty recruit. In our conversation, I tried to find the common ground between us, search for creative win-wins while keeping the faculty's interest at the center of the conversation. Sound familiar? Since we all have bosses, our palliative care skills are useful when not only leading our teams, but when we need to advocate for them. On October 13th, I met to plan our equity and anti-racism external advisory board meeting scheduled for November 12th. The goal of our EAB is to hold us accountable and provide us with feedback on how we are doing against the goals we set a year ago. We all need to become part of the struggle to make a positive difference and to advance health equity for all. In palliative care, we practice shared decision-making. In leadership, we try to achieve consensus. I am currently considering changing grand rounds in our department from Friday mornings, which it's been for 50 years, to Wednesdays at noon. On October 15th, we had a faculty meeting to discuss this issue. Like a big family meeting, it brought out many opinions and intense emotions. I am collecting the facts and will hopefully make the right decision on behalf of the entire department. In both palliative care and in leadership, one needs the courage to make decisions and the experience of knowing when to do so. In palliative care, we create roadmaps for patients and families to help them navigate the uncertain futures. In leadership, we strategically plan for the future and motivate and align people. On October 22nd, I participated in a strategic planning meeting with psychiatry to fully embed psychiatric and mental health services into our department. Just like in palliative care, we created a roadmap, set expectations, and developed clear follow-up plans. To do both well, one needs to think and communicate about the future often. On October 23rd, I had an absolutely wonderful hibachi dinner with some faculty and friends and sang happy birthday. Just like in palliative care, where we help patients and families find opportunities for joy in meeting, there is a universe of possibilities in cultivating the well-being within ourselves and other. I will also mention two cross-cutting themes used frequently in both palliative care and in leadership. One is a mindset and one is a skill set. The mindset is no matter how brutal the facts or how difficult the reality, it is important to maintain a sense of hope, optimism, and gratitude through it all. It is the role of both clinicians and leaders to support these dynamic, diverse, and often competing emotions. And the cross-cutting skill set is the judicious use of time-limited trials. Uncertainty is ubiquitous in both, and you need skills to manage it. To paraphrase John Keats, the physician poet of the 18th century, an effective leader and neuropalliative care physician is capable of being in uncertainties, mysteries, and doubts without any irritable reach after fact or fiction. When in doubt, insert a time-limited trial, but always know when you need to act. This table just simply shows this side-by-side comparison of these similarities between palliative care and leadership. Much of this I just reviewed. I am surprised that this topic has not received much attention in the literature, and I think deserves it more. Now, while there is tremendous overlap, there are definite differences. One of the most obvious ones is that in leadership, one has to understand, respect, and support the diverse interests of many more individuals and teams, and to do so in a balanced way. This requires a much tougher empathy when communicating, particularly with those who do not agree with your decision. But it is your job as a leader to build enough trust and to get the motivation and to get everyone on the bus. As a result, shared decision-making as practiced in palliative care is often not possible. In fact, a two palliative care approach can lead to complete dysfunction. And I call your attention to the prior book I referenced, The 5 Dysfunctions of a Team, to help you avoid. Another difference between leadership as chair and being a palliative care physician is my wife Rose's response to both. For years, she said, "You're happiest when you're on palliative care. Never stop doing it." In my role as chair, this is what she says, among other things. When are we done with this? I thank her for her never-ending support and encouragement, as I could never do either without her. Although her reaction to both might be different, it does speak to the critical commonality between both. Keep the home fires burning. These similarities, however, far outsize the differences. So as we finish up the meeting tomorrow, recognize the multiplying effect you can have as mentors, as leaders, and as advocates, whether you are managing up or down, whether you are working with institutional leaders, colleagues, donors, or policymakers, or whether you are negotiating for a new faculty position, fighting for resources to build your program, or establishing a new division or working with others to embed your services. Use your palliative care skills. As Benzie said yesterday, the future is now, and you can be the change that you wish to see in the world by just being you. And by doing so, we might even surpass that 10-point vision of the future where people and families actively participate, where international collaborations abound, where culture drives our strategy, where positive medicine becomes the standard, where we lift all providers to practice better, where we realign policy through our advocacy, where we ask more nuanced questions to drive innovation, and where we collaborate, appreciate, and embrace variability, our diversity, and provide access to this pursuit to all the talents that exist in our society and in our society. So in conclusion, for the International Neuropalliative Care Society to achieve its 10-point vision of the future, we need a leaderful society. I encourage you all to work with your mentors to develop or update your leadership plan. Many of you will be in leadership positions before you know it. And take advantage of the unintended consequences and use your skills to advance the vision of this incredibly exciting new field, a field we can proudly call our own. Finally, let's enjoy the journey. Both leadership and neuropalliative care are hard, humbling, and rewarding. Now we have work to do. Thank you for your attention, and I look forward to the conversation and questions to follow. Thank you.